All right. Good morning, everybody, and welcome to the Palliative Care Friday Chalk Talks. Today's discussion is on perceptions and unintended consequences of patients who elect to be a DNR compared to their full code counterparts. Our fabulous guest today has several publications in this area, most recently from JPM in 2024 and the Journal of Critical Care in 2022. Dr. Laura Johnson is an associate professor of surgery at Emory University School of Medicine and the chief of the burn service and the medical director of the Walter L. Ingram Burn Center in Grady Memorial Hospital. She's board certified in general surgery, surgical critical care, and neurocritical care. And when she is not in the hospital, Dr. Johnson is an avid saber fencer. Holy smokes, competing around the country and as part of the National Tournament Committee for the United States Fencing Association. Welcome, Laura.
Thank you, Dr. Bazelak. And I want to thank everybody who's here today. It's a privilege to be part of this group of people who is doing work that I think is so important.
Well, thank you. Our format today is going to be short and sweet. We've got about 20-ish minutes, and then we'll open it up for some questions from the audience. So we'll jump right into question number one. So we start with the why. Tell us a little bit about what led you to this topic that you've been examining for a while now.
So, I think that there are lots of people who have lots of moments, like seminal moments. And I would love to point to one in particular, but for me, it's a general sort of the contrarian nature in me. I think I've heard a lot of people over time say we do X, and I'm always like, why do we do X? That doesn't actually make sense. So I have had a really positive experience in my life with hospice care and end-of-life care, and I really struggle with making sure that our patients can express their wishes effectively and also get surgical care. And so that's why when surgeons, when I was a resident, said, oh, we don't do care for DNR patients, or I won't let my patients be DNR, or I rescind the DNR before I operate, it used to make me really mad. So that's sort of why I chose this.
So, in thinking about experiences of other clinicians, you and I've already talked about this a little bit, but in my own clinical experience, I feel like I rarely encounter, but I do encounter, but I rarely encounter clinicians that will explicitly tell me, why are we offering X, whatever X is? They're a DNR, which sort of suggests that they're using DNR as a surrogate marker for patients' goals. And the more I went down the rabbit hole, preparing for today and reading the literature, it sounds like there are lots of other clinicians that worry about this theoretically as well. And that perhaps this DNR bias, maybe we'll call it that, is something that we all have on some level, if we're honest with ourselves, and that we're maybe in various stages of acknowledging it and working with it, like so many other of our biases. Your thoughts on clinician perspectives on this?
So many years ago, I actually also, I've gone down the same rabbit hole. As you can see, it's been something I've been interested in for a while.
Yeah.
There's some very disturbing to me literature in subspecialties of surgery that people will actively not offer surgery to patients who have an expressed wish to be DNR, or frankly, other more specific advance directives that are not what we would consider full support in case of a unintended outcome. And it was reinforced by the work done at the institution where I trained at residency and went back for my first job, where they actually surveyed, because there's a very strong intensivist group who were mixed practice, anesthesia, EM, ID, surgery, and then frankly a very vocal group of cardiac surgeons. And so they surveyed it and identified that the surgeons really felt that care changed when patients were made DNR. And I found that's really interesting. Like, why? What is it about the DNR? Like, we need to talk about this, right? It's one of those unconscious biases that, as we think about and unpack our biases more effectively, I think in 2024 than when I was in training, we need to acknowledge these ones that are not quite as upfront in the media, but these ones about what does it mean to have a set of goals that are maybe not, I want to live forever.
Mm, mm. Your your 2022 paper, it took a look at some of the differences in the perceptions of the surgical and the ICU staff. And I'd love to get your perspective on why there appears to be such a difference between surgeons and non-surgeons, or whatever you feel comfortable sharing.
No, it's totally fine. I am I have often been accused of having too many feelings by some of my surgical colleagues. Okay.
But
Um,
welcome, welcome.
Thank you. And I'm on the record saying that now.
Yeah.
I think that, I think that there is a challenge in the way we are addressing outcomes in medicine, right? And I think for surgeons, there are especially a set of codified metrics, interestingly enough, in many of the subspecialties that have challenges with DNR. And those metrics can, when they're not interpreted correctly, this was actually shown in the trauma literature, that when you looked at specifically pure mortality indices, different centers will look very different if it's just mortality versus when you pull out patients and reassess the mortality indices, accounting for patients who had an expressed wish to be DNR, A&D, other things like that. And so I think that it's because we have different quality measures that I think because different quality measures were put in place, I think this is one of the unintended consequences of those measures. And I think that the way we combat that is by actively talking about it. I think in trauma, especially, it's been really well recognized that we do have to pull out patients who have advanced directives. And it's gotten a lot of support. And I think that's it's a surgeon population now who is very comfortable with the idea that somebody can be DNR and still have lots of interventions done to them during their acute hospital stay.
Before we move on, I'm curious, do you think that's changing? Because I mean, medical school training residency, that it has evolved so much over the last 10 years, talking about goals, thinking about palliative care, hospice, patient wishes. Do you think that's more of a generational thing and that will evolve over time?
I'd like to think so. I was actually back looking at some of the data from one of the impression survey, and the difference between 2012 and 2017 was not as robust as I would have liked to see.
Sure.
I think that I think you have to remember surgical training is anywhere from 5 to 10 years. And so it takes a little longer to wash out some of those perceptions. I mean, the surgical palliative care community is actually very mighty. It's a little small, but it's mighty and it's growing. And they're getting the word out, and people who are movers and shakers in surgical education are advocating for education on this, and discussion of this. So I think we will see some movement, but like, I apologize, we're surgeons. It takes us a little time to change.
No,
So
takes us all a little time to change. We have our own things as well. So you're in good company. Um, I assume we've all encountered patients that have told us that they don't want to be a DNR because they fear they're going to be treated differently. And when they divulge that to me, my approach is to talk about the elephants in the room. So number one, yeah, well, I will talk to them about, while I do not believe that they should be treated any differently because of code status. And in my experience, I think overwhelmingly my patients are not treated differently. That number two, humans have biases and they are imperfect. And I've heard, as I shared a couple questions ago, some things that suggest that it is possible, even though I'm going to advocate the heck for you here in the hospital, I'm going to make your goals as clear as they can possibly be. And so assumptions aren't made. And I'd love to hear your thoughts on patients who share these fears.
And first of all, I always congratulate them on being honest with me like that. I think unfortunately there remains this unanticipated, unwished for still sort of distance between our patients and ourselves. And I think that acknowledging that it's super brave of them to tell me this, and that yes, they are right, that there are still places in medicine, in even my hospital, my last hospital and this hospital that I'm currently at, where that might happen, is real. But I think it's important to understand from them what their goals are, right? Like I feel like all of my conversations these days have been about what are your goals, what are your trajectories, right? Like with my, like, what is the goal of what we're trying to accomplish for the patient? And once I understand their goals, then we have a discussion about, well, we can, there are ways that we can write DNR in the chart. There are ways that we can communicate what you're trying to achieve, and make sure that ultimately when you are, like, whatever the outcome is, we accomplish what you want to accomplish. One of the privileges of being medical director is that I can start to set that tone on my unit. And frankly, because I was the last person to walk into a room for a larger meeting of critical care in this hospital when I first showed up and got made chair of the committee, I can actually start to have these conversations and move the tenor of what's happening. But it's not unreal. It is a real concern. The other thing I do, I think, is when I talk to physicians who strongly advocate for patients to be DNR, I'm always like, yes, good job, right? Like when I get transfer requests or calls for consultation at outside hospitals and they can actually tell me what the DNR status is and what the patient's goals are, like I reinforce that that's super important. And I'm asking people, like, what are the conversations? Because if we don't make that part of our normal discussion about patients, no matter what age, race, injury pattern they have, then we won't make any forward progress.
I'm so impressed. As I listen to you talk, you sound like a palliative care clinicians. You really do. You do. So
we are all palliative care clinicians. Palliative care is
I love that. I love
right?
that. Okay.
I mean, trust me, I can't do what you guys do from the complex discharge perspective. One of my grandmothers was in hospice. I like to tell people she graduated 3 times, right?
Wow.
She did well twice and
Wow.
got out, and then the last time she died. And so that's not a space that I can inhabit, but symptom management is something we should all be thinking about.
All right. Let's move on to your paper. So tell us a little bit about your most recent paper from 2024 and how it adds to this existing understanding of the issue.
So the first thing I want to do in talking about this paper is acknowledge literally the blood, sweat, and tears that the first author put into this. I mean, Catherine unfortunately did this paper and then decided she wanted to go be a gastroenterologist, and because she was about to do critical care, and then she went through all of this work with me, and I am really sad. But this is such a hard thing to study, and the question of how do you set up an intervention? What's the intervention group? What's the control group? I mean, the question I wanted to answer, so let me back up. The question I wanted to answer was, does care actually change? Right? And it's such a subtle, like, how do you measure the approach that a human takes to another human in a critical care space after you write 3 letters on a chart? So it took us a while to figure that out. And then even with the cohort groups that we set up, a lot of the feedback we got on the paper was, well, why didn't you do X and why didn't you do Y? And I kept wanting to be like, have you ever tried to do a study like this before? So we looked at patients who were in the ICU for more than 48 hours, who had had a DNR order placed more than 48 hours before their death, because I'm sure all of you are familiar with this idea that, like, literally we put DNR on the chart 30 seconds before the patient's epi runs out. And compared them to a cohort of patients who also, essentially made it an extended period of time in a critical care space, to see whether the number of interventions that were performed changed. And we did it in multiple centers. Catherine found a contact at Utah, so we've done it with some colleagues in a totally different part of the country. In a VA setting, in a private hospital setting, in a large inner city urban academic trauma setting. And at baseline, what we identified is that the interventions that my surgical attendings had complained wouldn't happen a decade earlier, right? Treatment for arrhythmias, dialysis, transfusions, actually didn't differ between the 2 groups. So to me, that was really heartening. Like, they had less surgical interventions, which is another topic that we will tackle. I will have to continue to tackle with my colleagues in the future. But the critical care, right? And that's, we all care for patients. We care for, no matter what we're doing, we're caring for patients. But the idea that my surgical teachers used to have is that, oh, they'd get pain meds and they'd get, like they'd get not aggressive care, was proven to me, suggests from this data, I don't know if it's 100% proven, but it suggests that maybe that's not what's happening. Why it's not happening is a totally different conversation, right? Is it because we have intensivists in these three areas that are specifically attuned to the difference between DNR and like complete change in trajectory of care? I don't know. But it's at least evidence that you can have a DNR, to me, evidence you can have a DNR order in place and continue to get aggressive intervention.
Yeah.
Aggressive intervention for a goal that is curative intent, shall we say, as opposed to, because again, I don't want to imply that you guys are not also doing aggressive care. You are, but the intention of the care is different.
Gotcha. Yeah, that kind of gets at the quote that I pulled out that I liked about your paper. It says, quote, while some providers worry about the impact of DNR orders on overall patient care, this provides some reassurance. Providers do not limit invasive, non-surgical interventions indiscriminately, which kind of fits with my experience that this seems like something that may be possible, but seems uncommon and very rare. So fair.
We need to do better, but we can do better. So.
So we just have a minute or two left. I'm going to jump to maybe our last question, and then I will open it up to the floor to see what questions other folks have. And this is the maybe the magic wand question, which is, what do you wish would change, and how do we help improve clinicians with this topic?
So call me a dreamer, but I sort of wish that the EMR frankly went away, or was less like it's less. We need to return our focus as clinicians to the patients in front of us, right? Goal-oriented, trajectory-focused care is what I'm trying to encourage in my residents and medical students and nursing staff and therapy and everybody, right? Like we need to reconnect with what patients want. And then we need to figure out how to make that happen. And when we can't make that happen, we need to be honest about it. But without that relationship with the patient, it's very hard to limit to limit them, because that's essentially what we're doing, right? I meet people on the worst days of their lives, and I meet families on the worst days of their lives relative to their loved one. And so it's a very hard, intro. But if you spend the time and put in the effort, then you can actually, you guys all know this, right? Like it allows for healing and strengthening of that healthcare patient relationship across both the patients that we take care of and the patients we're going to take care of in the future, who are these family members of people in really, really difficult spaces. So
yeah, I have similar beef with the electronic medical record. I will see goals of care note templates that all they have documented under goals of care is the code status, which sort of perpetuates that DNR orders are somehow a surrogate marker for all of the patient's goals, rather than some specific treatment preference. So
agreed.
So if anybody has any questions, you can type it in the chat or use the raise hand function. And until then, Laura, I get to continue to keep picking your brain with a few more things.
All right. Love it.
As a surgeon, I suspect you run into the palliative care team periodically. Any advice for us? Because I love asking people who are outsiders, what maybe are our blind spots? What could we do better to work with the surgical community? This is a safe space. Any advice that would make us better on like a day-to-day basis?
So first of all, we actually have an active palliative care screening tool for our patients at admission. So we have a list of I don't know, probably 15 criteria that are like, okay, we need to call palliative now. So I love my palliative care colleagues, and I see them. They probably don't want to see me as much as I'm like, oh, good, you're on the unit. But I think I think we have to continue to dispel the myth that palliative means end of life, right? And I think that that's like when we can talk to each other about the goal. So if I were just some random surgeon, I'm like, okay, fine, palliative. If the palliative care physician was like, well, so what was your expectation of what was going to happen for this patient? And I see the hand raised also. And how can I help you achieve that? Is going to go a long way, right? Because I think sometimes, again, especially if you're getting called for a patient who's had an unexpected outcome from an elective operation, I think that surgeon is also in shock too, and grieving, as it were, in their own particular way. And so I think a little bit of, I would ask for a little bit of compassion for these people who, again, are not used to expressing their feelings, but have them and don't know what to do with them. So
yeah, I appreciate that. Maureen, you can unmute and ask your question.
Actually, Rose. It's Rose.
Oh, sorry.
So at our institution, we have an odd DNR order. Speaking of the EMR, it has all of these pre-arrest situations. So does the person want intubation? Does the person want antiarrhythmics, pressor support, cardioversion? I have always hated it because it's very difficult to explain to patients. But now I'm starting to think maybe it's also helping some of these conversations about, you know, how far do you want to go? We know you don't want to be resuscitated, but in this scenario, are you okay with XYZ? So this conversation has kind of helped me think a little differently about it. It's still super clunky, but maybe that's why people aren't just being written off when they're DNR. There's a little more explanation in there.
I think, you know, it's, again, and I come at this from the procedural side because people will ask surgeons, right, can we get a trach and peg for this patient? And I'm like, okay, what is the goal? And I've had patients say, I'm perfectly happy to be intubated for short periods of time, but if this is going to extend for like months and months and months, I don't want to be a burden on my family. I don't want to be in a skilled nursing facility for the rest of my life, getting turned every, hour, hopefully by a nursing assistant, right? And so, but I'm perfectly happy to have a trach and be at home on my Barker lounger watching the golf in the afternoon, right? Like, so understanding what they want and then figuring out what interventions I have that can help achieve that, but also what interventions I have that won't achieve that. Like, if I have a heart failure, I used to do a fair bit of cardiac ICU. So we get a heart failure patient in who's in VTAC storm and is constantly getting shocked by their AICD, and they're like, I don't care, turn this off. This is miserable. Sometimes the surgeons were like, no, you can't do that. They'll die. And I'm like, have you ever been shocked like twice a day by an AICD? Because I haven't, and I've watched it and it looks miserable. So, I think some of those laundry lists are helpful for the more nuanced patients that we see, right? Like the ones who have lots of healthcare experience, the patients who have been in with AICs or LVADs, or who have been, on bypass for a while, or have had neuro devices and things like that. They can actually tell us what they want and what they don't want. But again, for patients who are new to the healthcare system, I think it's important to be like, what do you want to accomplish? And would 3 days a week chronic dialysis impact your ability to do the things that you love with your life? And if the answer is no, then great. That's definitely something that we can, CRRT to dialysis might be something we pursue. So I don't like giving it to patients as like a pick the things you want, right?
A la carte.
It's not an a la carte menu, but it's given what their goals are. These are the things I think would be supportive of those goals, and these are the things that would not be supportive of those goals.
Perfect. there's a little smattering of commentary throughout. I did want to highlight Richard's because I think it's nice to highlight that hooray for palliative-minded surgeons, and just wanting to make sure that everybody's aware of the Surgical Palliative Care Society that is out there.
Yeah, I'm a member. I have to pay my dues this year, but yeah, small but mighty.
Small but mighty. One last quick question, then we'll let you go for the day. Is there anything coming? Are you working on any other projects related to this? Something we should be looking forward to?
So I have recently instituted a change in the palliative care implementation guidelines at my new institution. So we're looking at how that's impacted relations and interactions and thoughts about patient care. These sort of bigger projects that are tilting at these kinds of windmills, I mean, I'll freely admit my questions in medicine are big and why, like the big questions, the whys, the hows. I am thinking about, again, how do you simulate conversations about this? But that's in sort of still in my brain. It's not on paper yet. If anybody has ideas, I'm happy to collaborate. Like, I love this. And again, I love it. It comes from a place for me where I think this is patient-centered, patient-focused approaches. And all of us as in the medical community, it's our responsibility to champion this. So.
And I'll include your email to the group, so that way if anybody wants to reach out and try to work with you on this, maybe they can do so. So,
please.
All right, Laura, you have just the right amount of emotions, not too many.
Thank
You are not small, but you are mighty. Thank you for joining us today. We really appreciate having you.
Awesome. Thank you guys so much. Have a great day.
Thanks. Bye.